Good afternoon and welcome everyone to the Center of Research Excellence in the Prevention of Falls-Related Injuries Seminar 3. And today's seminar topic is delivering online exercise in different populations of older people in the community. But before we start, I would like to acknowledge that I'm hosting the meeting from the lands of the Gadigal people of the Eora Nation and the traditional custodians of this land, and I pay my respect to elders past, present, and emerging, and recognize and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connection to the land and waters of NSW. And I extend that respect to Aboriginal and Torres Strait Island people here today. All right. So today we are going to have four amazing presenters with us, and they all are presenters. All the presenters today are researchers at the Institute for Musculoskeletal Health at the Faculty of Medicine and Health in the University of Sydney. And so we are going to have first presenter as Professor Anne Tiedemann, who is a professor of physical activity and health and leads the healthy aging research team at the Institute for Musculoskeletal Health. Her current research focuses on the development and evaluation of scalable interventions to promote physical activity and prevent falls in people aged 50 years and over. And then we're going to have our second presenter as Dr. Abby Haynes, who is a research fellow in the Sydney School of Public Health at the Institute for Musculoskeletal Health in the Faculty of Medicine and Health. And her work recently has revolved around the qualitative aspects of the intervention programs in the physical activity team. And then we are going to have Dr. Heidi Gilchrist. Heidi is a lecturer and early career researcher in the Sydney School of Public Health at the Faculty of Medicine and Health. Her work is also revolves around the qualitative aspects of the intervention programs in the physical activity team. And then lastly, we will have Dr. Rick Dawson, who is a former CRE-PFI candidate as well, and now a postdoc researcher at the University of Sydney, Faculty of Medicine and Health at the Institute for Musculoskeletal Health, and an experienced aged care physiotherapist. And Rick has recently completed his PhD, where he investigated the effectiveness, cost effectiveness, and acceptability of physiotherapy-led exercise programs delivered via telehealth for older Australians. And so, yeah, welcome everyone. And we will have a question and answer time at the end of the session, but please feel free to put your questions in the chat box and we'll look those questions. So now, without taking much time, I will stop sharing my screen and hand over to Professor Anne Tiedemann to share her screen and kick off today's seminar.
Okay, so hopefully you can all see my screen well. So thanks very much to the CRE for inviting me to present today. So as Vithika said, we're going to be talking about online delivery of exercise programs for older people. And I'll be kicking off with some background about the SAGE yoga trial. And then that'll be followed by my colleagues, Abby and Heidi, who will talk about the participant experiences of the trial. So I'll just do the background to the trial. So this is focusing on yoga. So we know that surveys show that yoga is one of the fastest growing leisure time physical activities, particularly for older women. And the research in the falls prevention field has shown there's a large amount of research around exercise for fall prevention, but not much in terms of looking at the effects of yoga-based exercise for preventing falls. And so after a bit of background research over the years, looking at whether yoga would be a viable and feasible possibility for preventing falls, we were lucky enough to receive funding a couple of years back from the NHMRC to conduct the first trial internationally, first rigorously delivered trial of yoga with falls as the primary outcome. And so our aim was to measure the effectiveness and the cost effectiveness of a group-based yoga exercise program on falls, and we compared it to a seated yoga relaxation program. And this was amongst 700 community dwellers aged 60 years and over. So just a bit more about the intervention. So it was a group-based program delivered over 12 months. The style of yoga was Iyengar-based yoga. So this really focuses on standing balance postures, so discrete postures rather than flowing movements. And we selected that type of yoga because we assumed that it would be a little bit easier for novice older adults to learn that type of yoga. Each session went for around an hour, and there was a frequency of two sessions per week. And participants were also encouraged to practice at home at least twice a week, because we know that to prevent falls, we really need to have a high dose of exercise. And so they had a home practice book, and so they went through this program, slowly increasing the intensity and the challenge to balance over the whole 12-month period. And so in comparison, as I mentioned, the control group received a seated home-based yoga relaxation program. And so this was taught in 2 supervised sessions of 1 hour duration each. They were then given a printed booklet that helped them to go through the program, and they were directed to undertake this yoga relaxation program as often as they wanted to and in their own time. So things to note about this trial is that originally it was designed as a face-to-face yoga intervention. We had planned to deliver the program in yoga studios around Sydney. And so we started our trial in October 2019, and we'd had a few groups started when COVID hit in March 2020. And so this was very stressful, but pretty soon after this happened, we pulled ourselves together and we came up with a plan to deliver the yoga program online via Zoom. And so this presented challenges as well as opportunities. So first up, the opportunity arose that we could then recruit participants from throughout New South Wales rather than being restricted to Sydney only. So that was in our favour, and it really boosted the recruitment to the trial. We were concerned about the loss of social connection from moving from the face-to-face delivery of the program to online. And so to combat that, we offered people within each class the opportunity to be connected to each other via a WhatsApp group for each of the classes. And many people found that that was well received, and they did use that opportunity to keep in contact with their classmates. And so what were our results? So we managed to recruit our 700 participants, and it only took us around 2 years. So it was really well recruited to, and we had a waiting list of a couple of hundred people who didn't make it into the trial because we filled all our spaces. You can see the mean age was around 66. Most were female. Around half of the sample had done yoga previously, but one of our inclusion criteria were that they weren't supposed to be doing yoga at the time of recruitment. And around 30% of our sample had indicated that they'd fallen in the past year. The class attendance was very good. So you can see the stats there. People, they really welcomed the opportunity to have this structure, particularly during the COVID lockdowns. And so people attended the class as well. And overall, they felt very positive about the experience. Now on to the results. Well, we had some very surprising results with this trial, and we haven't published this work yet, so I'd ask you not to share the results just yet publicly. But surprisingly, the yoga exercise group actually experienced significantly more falls than the control group in this trial. So we had 276 falls experienced in the yoga intervention and 164 in the relaxation group. And this was an incidence rate ratio of 1.33. So it was a significant increase in falls in that yoga exercise group. We did find positive impacts between group differences in physical activity, balance, confidence, and goal attainment. And this was in favour of the yoga exercise program. So we were very confused by these results, and we seem to, our explanation is that possibly the yoga intervention that wasn't the right type of yoga to actually provide enough challenge to balance to protect people against falling. And also possibly the online program, the online format did not allow for teachers to challenge their participants quite enough to get that benefit in terms of falls. But what we're really talking about today is how to deliver online exercise. And so overall, the feedback was very positive. People felt improvements. They liked the sessions. They felt supported by the teachers. And my colleagues will talk a bit more about this in a minute. But what I mainly wanted to share was that the online delivery of exercise was well received in this trial. And actually, some people preferred the privacy that online exercise offered to them rather than being in a room with other people. We found that the key tips for success in the delivery of the program were that we needed to provide very clear instructions and support about setting up the online system, how to use Zoom. And this was earlier on in our COVID experience, and so not as many people had used Zoom at this point in time. We actually instigated an initial one-on-one Zoom call between the participant and the instructor. And this was really important in allowing them to get to meet each other, have a short chat about any possible worries that the participant had about taking part in the yoga program, and for the instructor to get to know any modifications that they might need to provide for that participant. We restricted the class sizes to around 15 to allow for the instructor to be able to manage those people on their screen. We provided a variety of class times throughout the day because a lot of people were still working. And as I said, we provided the option of using WhatsApp to provide that social connection amongst the class. And so that's where I'll leave it, and I'll hand over to the next speaker. Thank you.
Hi everyone, I'm just sharing my screen. Give me a shout if it looks right to you. Okay, check that. Great. Okay, thank you. So Heidi and I are going to talk about different aspects of how the SAGE yoga program engaged participants and supported sustained adherence. I'll briefly describe the evaluation methods we used and then give an overview of participants' views and experiences of SAGE. And then Heidi will talk about the strategies the yoga instructors used, including how they adapted to online teaching. So our findings came from a realist process evaluation. As you may know, realist evaluation seeks to develop theories about how programs produce outcomes for different people or why they don't. It's a response to the classic approach to evaluation, which often glosses over causality. You can see in this logic model template, causal mechanisms are just implied by those red arrows, whereas realist evaluation focuses on mechanisms of change. So it wants to understand what's going on in those arrows as much as in the boxes. And the evaluation typically asks how and why questions in relation to linkages between the intervention activities, the context they take place in, possible mechanisms of change, and any observable effects. And when applied to process evaluation, the effects we sought to develop explanations for related to participants' engagement with the SAGE program. Throughout the transition to online yoga, and in fact through all phases of the trial, we were seeing really high adherence and very positive feedback from participants, indicating high levels of engagement with reports of improved physical function, sleep and well-being. And we wanted to understand this better. So we co-developed initial program theories about what was working in relation to that hybrid program. So that's where people had signed up for and started in studio-based classes and then moved online. So those participants were able to compare the two different modes of program delivery. And then we further tested those theories with later participants who signed up for and took part exclusively in online classes, otherwise known as tele-yoga. Realist program theories are developed primarily through consultation with the people who are taking part in and delivering the program. So we conducted iterative rounds of interviews and focus groups with these stakeholders, and that was supplemented by feedback forms, observations, and process measures. And these are the program theories we ended up with. Each of them is based around mechanisms, which are shown on the right, that we identified as best explaining participants' engagement with the program across both those modes of delivery. And I'll look at each of those theories briefly now with specific regard to the online delivery. So participants described many benefits which made SAGE worth the effort. It was especially valued for supporting individualized, age-appropriate and holistic practice. And that impacted multiple aspects of health and well-being. But a few people found they couldn't manage pain and they felt that yoga was exacerbating it even with modifications. The online format specifically had quite positive and negative impacts on how the program was valued. So the most problematic aspect was reduced visibility. Around half the interviewees who attended the hybrid program felt that online classes were inferior because their yoga instructor couldn't observe them and correct them as effectively via a small 2D screen. This is a screenshot of an online class from the instructor's point of view. And it does show that there are varying degrees to which participants can be observed, and that's affected by lighting and the position of their device. But this concern was much less prominent in that second phase of evaluation, where people had only attended tele-yoga classes, and so they were perhaps less inclined to compare them unfavorably to studio classes. Initially, there were also some concerns about being able to see the instructors clearly, but that was barely mentioned by people who only took part in tele-yoga. This slide does show how participants were asked to configure their screen. So as you can see, they could see the yoga instructor pretty well, but there is reduced visibility of peers, and that had positive and negative impacts for different people, as I'll mention in a moment. Not surprisingly, confidence in the yoga instruction was vital. So characteristics such as credibility, empathy, and teaching skills, including the ability to lead a whole class while simultaneously attending to individual needs. But we found that excellent online yoga instruction required additional skills, and Heidi will talk about those in a minute. Confidence in tele-yoga was definitely supported by the introduction of that one-to-one meeting that Anne described earlier, where individual participants and their yoga instructor had a discussion which generated rapport, and it really seemed to reassure participants that instructors understood their needs, and it gave them confidence to take part in what for many of them was a potentially intimidating activity. Participants were also clear that yoga had something different to offer. Relaxation, focused breathing, and that emphasis on mind-body connection were described by many as more engaging and satisfying than conventional exercise. We identified two mechanisms relating to this, mindfulness and embodiment, and they were both retained in the online program. And surprisingly, for some, they might have even been enhanced by the solitude of online practice. We all know how important social interaction can be for sustained physical activity, and the limited social interaction in online classes was a definite downside for some participants, but perhaps not to the extent we anticipated. Many people reported a sense of communal effort and solidarity simply by doing a program live, over time, and with a consistent group. And as you'd expect, tele-yoga offered greater accessibility and convenience than studio classes. People could attend with no commute from diverse locations and in diverse circumstances. So, for example, quite a few people attended while they were on holiday. And in one memorable case, someone attended while they were in hospital. But technology itself can present accessibility challenges. And these were experienced by many participants and the yoga instructors, particularly early on. So those one-to-one pre-program meetings really did help participants test their setup, but that was definitely backed by considerable support from the SAGE team, who offered IT coaching, and they also lurked in early classes to intervene if needed. And across both modes of program delivery, free classes enabled people on very low incomes to participate, some of whom told us that they wouldn't have been able to participate in paid classes. But the benefits of teleyoga weren't just about convenience. Some online participants revealed they would not have enrolled in studio-based programs because they felt too self-conscious in a face-to-face setting. So while reduced visibility online was a concern for people who wanted optimal observation and instruction, it was actually a bonus for some others. And a few people explained that limited visibility of their peers online made group practice less distracting, and it reduced feelings of competition, which also helped to facilitate that greater inward attention. There was definitely some suggestion that there's less accountability online. It's easier to slack off if you can't be seen well. But many participants did tell us they were motivated by their instructors commenting that they could tell who was working hard and who had done their homework. Lastly, interviewees said the program of twice weekly classes gave their week a sense of purposeful structure. They were adamant that once a week would not have generated that momentum. So that frequency, together with clear program progression and the accountability that live classes promote, even if online, helped them make yoga a habit during the program. And we know anecdotally that many have sustained that habit. So the SAGE teleyoga program worked well for most participants in our study, although that was probably enhanced by COVID restrictions and then the anxiety and the aftermath of COVID, during which time people were generally more enthusiastic about online activities. Teleyoga can't facilitate the same quality of observation or interaction as studio-based classes, but we did find manageable strategies for optimizing online visibility, instruction, social connection, and rapport with instructors. And the importance of these responsive interactive factors suggests that live classes are likely to be more attractive and effective than generic yoga videos. Teleyoga increases accessibility, including for people in regional and remote areas, and for some it provides a psychologically safer space. Importantly, it has the potential to be offered relatively cheaply at scale, and that could support free or reduced price classes for people on low incomes and pensions. So in terms of scalable costs, reach, acceptability, and sustainability, teleyoga offers one positive way forward for both fall prevention and healthy aging more generally. And here are the papers that describe this research, including the work that Heidi will tell you about now. So I'll stop sharing and pass over to her.
Lovely. Thanks, Abby. Can you just tell me, can you see the right slide? Perfect. Great. Okay, let me get all sorted here. Okay, so yeah, building on what Anne and Abby have described, I'm just going to speak a little bit about a paper that we wrote that focused on the yoga instructors' experiences of moving to teleyoga. Which we thought provided some really practical information about the process for other instructors. And in particular, we wanted to describe the challenges and benefits faced by the yoga instructors and also describe how they adapted and managed those challenges. And we used the data from several different sources from our realist evaluation, and this triangulating of the data help to increase the trustworthiness of these findings. So our instructors were very experienced, but they hadn't taught online, nor had they done any training on how to teach online. So like most people around that time, they described feeling very overwhelmed. And they identified 4 main challenges adapting to the online environment that I'll run through first, and then I'll talk about those 8 different strategies there that they discussed. So as Abby has said before, the threat to safety, the safety of the participants was by far their greatest concern. And there were a few different aspects to this. So firstly, they couldn't use their hands to adjust people as they would in a studio. They couldn't move around them to check on a person's position. They couldn't fetch a standard size prop or block or bolster to support someone to achieve a position safely. And then lastly, and one I hadn't given much thought to, was the lack of audio feedback from the participants who were asked to mute at the start of the class, meant that they can't hear their breathing, so it makes it difficult to judge the intensity of a class. I'm just going to, I'll talk to these slides and you can just read the quotes. I'm not going to read those out. Secondly, the online format created a more communal experience, which again surprised us, because even though everyone was isolated, there was no possibility of having those confidential sort of private asides with participants within the class. So once a class begins, because the participants were muted, they would have to come forward and unmute themselves to speak to the instructor, and everyone would hear. So the instructors felt that this, combined with the lack of touch that they normally had in classes, both altered the interpersonal dynamics. And the instructors also worried about the mind-body connection, because it was so important to people in yoga, and the yoga movements are normally performed accompanying breathing exercises, and they described how that's really important for hearing people breathing in unison to help participants be present and focus. And because they're muted, and you can only hear the instructor, they were worried that it would lead to a more physical and less mindful class. So, and also because they had less enjoyment over the participant, less control over the participants' environment. So distractions like pets and family members could also lead to a less mindful experience. And then as Abby's mentioned as well, there was the technology. So all the yoga instructors and participants were on a steep learning curve with the technology required for teleyoga, and some of the instructors in particular worried it would be impossible for themselves, let alone for the participants. So talking now about the modifications or the strategies that the yoga instructors employed, they all commented that although it had been a steep learning curve, the process had made them better instructors. And they identified 8 main techniques that were essential for this revised practice as teleyoga instructors. And first of all, the one-on-one interview was really important. They advocated for that, and for them it served several purposes. It was an icebreaker. It served to develop that rapport that they would have normally done, in class. And it allowed them to do a physical assessment to look at any limitations that the participants had, and also an environmental assessment. So help them set up their space as adequately as possible, because everybody was working in different restrictions. Secondly, they, in the absence of being able to hear or touch the participants, the choice of words was even more important. So they spoke of things like bullet pointing and giving less intricate detail and more time to absorb, and also focusing more on teaching the participants safety and responsibility for their own bodies, which sort of overlaps with the next strategy, which was this increased focus on interoception. So where proprioception refers to the perception of one's body and muscles and joints and where they are in space, the interoception is a technique that they use in yoga to facilitate mind-body connection by looking inwards and focusing on sensations from inside the body. And the instructors described how this was even more important in the online context. Fourthly, there was a bit of a debate around this one. Several of the instructors thought it was really important to call people by name and to practice that sustained connection, and also for safety. But Two of the instructors were a little less inclined to do that because they didn't want people to feel singled out or criticised. But regardless, they all felt that it was important to focus on techniques to increase connection and support. So if they didn't do it by name, they did it by strategies such as things like a few minutes of small talk at the start of the class, inviting people to stay back with questions after the class, making sure that everyone had their number and email, and regular mail outs were all aimed at increasing that sense of community. And then the sixth modification there is a slower, more structured class. So all the instructors described how a class that was with a slow progression and a lot of repetition was the type of class that worked best, particularly for older participants and with this level of experience, because most of them, were not experienced in yoga. The instructors also relied more heavily on individual modifications to ensure safety. So they all acknowledged that quite often they didn't reach the endpoint of some poses that they had planned in class originally. So they described several postures that they had modified to ensure that the class practiced them safely. And then lastly, but importantly, was the IT support. So from our RAs in the early weeks in particular, they mentioned that the troubleshooting for the participants was invaluable, and providing Zoom links also for the instructors, so the instructors could just focus on the delivering the best class that they could. But they also acknowledged the determination of the participants, as you can see from this quote here, and they really admired the persistence that their participants showed. So in summary, I guess, although it's only a very small group of instructors and it's under trial conditions, so it's much more controlled than the real world, there's definitely some good insights here that we think can provide some pragmatic strategies that can overcome the challenges of online classes and potentially increase engagement, not just for tele-yoga, but hopefully potentially with a wide range of tele-health classes for older people. And that's just the paper that we wrote about it, if that QR code will take you there if you're interested. And I'll stop there and hand over to Rick. Hang on, Rick, I've got to stop sharing.
That's okay. Okay. Hi there, everyone. I thought I'd just share some of the insights from some of the projects I did in my PhD, which did foster focus on delivering a telehealth trial in aged care for older people. But as a part of my PhD, we did a systematic review, and just to explore the topic of telehealth, there are two types of telehealth as defined by the World Health Organization. There is synchronous telehealth, which is sort of what we're doing now, which is real life, real time, where a health professional talks to a clinician, talks to one of their patients. But there's also asynchronous telehealth, which we sort of know now as, exercise videos or exercise and educational resources. It could be things like text, but everything that's sort of planned and not existing in real time. We did a systematic review, and we only found 5 randomized controlled trials that looked at the effects and impact of telehealth to deliver exercise interventions to older people in aged care. And some of the barriers that when we did an implementation analysis of the trials is that there was some hesitation for this population about using telehealth, but it was mixed, wasn't necessarily age related, it was more skill related. There was some challenges around delivering having multiple Zoom platforms out there, like Heidi and Abby were talking about, say 15 people in 15 different homes. The challenges about delivering adequate exercise dose and intensity was brought up as a barrier from a multiple sites and synchronous. And there was also some hesitations around, can we deliver sufficient exercise tailoring using asynchronous exercise programs? And to facilitate telehealth in aged care, they need a lot of training. They need ongoing support, face-to-face or phone calls. But what was really, what the participants liked in this review is that they like to be able to use the asynchronous resources when it suited them. And the fact that they could do their health program at home was really convenient. So that's research influenced the development of our protocol and our trial. And I know a lot of you have heard a little bit about the top-up because I've been doing the rounds at different conferences exploring the results. But it is a hybrid type 1 effectiveness and implementation. We wanted to know whether a solely telehealth model was successful, safe, and effective, but also what was it about our approach that might have influenced its impact. We had a strong co-design partnership methodology from day one with lots of consumers from my previous business experience, people that have used telehealth or are existing in receiving services in aged care, their family, physiotherapists, and aged care staff. And an economic analysis of the trial is planned for later in the year. So looking at our systematic review and all the work that the Institute where I have done my PhD on, there's a lot of pre-existing work around how do we develop some models of telehealth that really enhance the capability, opportunity, and motivation for older people or our participants to stick with exercise? And can telehealth optimize motivation using self-determination theory? Can a clinician develop the trust that we know we can do in face-to-face interactions? So this is what the program looked like. We aimed to deliver 10 telephysio sessions over Zoom in 6 months. We wanted our participants to exercise for 2 hours a week of moderate intensity, strength and balance exercise based around the Otago project. But we also appreciated the support that they needed. So every participant received 1 hour of support from a trained care staff each week. And so this is what our participants looked like. So they were older, predominantly female, predominantly Australian born, almost 50-50 split between residential aged care and home care. And we had nearly 40% of participants came from rural or remote areas. Ethics prohibit us from working with people with severe cognitive or physical impairment. And we had just under 50% of people enrolled in the trial that had either mild or moderate cognitive impairment. They had complex health, they had lots of meds, they needed lots of support to walk with walking aids, and at least half of them had had one fall or more in the last 12 months. And when you look at their technology readiness, we used a scale called the TRI, the Technology Readiness Index, and 5 means they're early adopters, they love tech, they love using it, and we were most of the participants were under halfway around about the 2. So they were late adopters, which I can imagine is not surprising for a lot of you, but they were exercising, and we started recruitment just after the long lockdown in 2021. And it was interesting, the participants who wanted to do the trial were pro-exercise. We got to 242, and we lost about 31% of participants to the final follow-up, mainly due to health reasons. COVID-related, unfortunately, they passed away, became unwell, and we only had 3 people in the intervention group that withdrew from the trial because they didn't like it. And this is some of the implementation outcomes. So a lot of my aged care partners that I initially approached wanted to be part of the trial. About 75% signed up. And you have to acknowledge that we were still living in that horrible COVID years where aged care facilities were constantly in and out of lockdown. So that was a really good adoption. Our reach was low, primarily because each site said we'd love to do the trial, but we can only do a few residents because we just don't have the staffing capacity to support it. So our reach was about 18% of all the participants who could have partaken in the trial. We are able to deliver local support weekly, and the physio sessions were a little bit lower, primarily because we had a lot of staffing issues with COVID with the physios from all the different aged care partners. That was the majority reason we didn't get the 10 sessions over the 6 months. And we got the participants exercising on an average of 1.3 hours of strength and balance. So we went a long way to achieving the outcomes of the trial, and we only had one fall during the program. Excitingly, we had about half the participants who did some independent exercise, either with the exercise book or with some of those asynchronous resources that we developed on our website. And you can see here on the left is my mum, a snapshot of some of the videos, and a client on the right doing some of the exercises. I've just developed a drafts article exploring the effectiveness outcomes, and we had some really pleasing results. We're able to improve their mobility by 2 points on the short performance physical battery scale, which is in a combination of looking at how fast they can walk, what their balance is like in standing, and their ability to do transfers with and without hands. So that's a really clinically significant, important result. When it came to the rate of falls, we almost were significant. And when you look at the intervention group, there was a 40% reduction in the rate of falls compared to the control. And importantly, we were able to reduce the proportion of fallers by, if I can just move my, by 38%. Quality of life improved. Pain reduced by 1 point on the VAS scale, which is a very common physio scale when we ask someone to rate their pain out of 10. And that is similar results to many trials that focus on pain as a primary outcome. I just want to explore a little bit of the tips and the advice that we got from our qualitative analysis. So we interviewed 18 people that did the trial, 7 aged care workers who supported the trial, 7 managers who enabled the trial, and 6 physiotherapists from across metro, regional, home and residential aged care. And there's a little QR code there to look at the paper that we published in the Journal of Medical Information Aging, an American journal. And here are some of the facilitators. I'm just explore them one by one. Like a lot of telehealth programs, people find it really convenient. It expands their opportunity to do exercise, and they really find it a cost-effective way to get to see a health professional. The resources and the approach that we used by using older people in the videos, creating videos that were senior friendly, or, you know, clear text, good lighting, those sort of things. They really liked that. They loved the modeling aspect and the simplicity. And they liked the fact that the video started really easy and short and increased in complexity as they progressed. And the physios supported them along their journey, which brings us to the next point. It's not just the physio input that's important, it's the local support that's important, and it's together. It was like a team approach, person-centered care, putting the client at the center of the interaction and supporting them to achieve their goals. It was a flexible program, and they really liked that they could choose when they could exercise on their own. And so they really enjoyed that. But the managers all said telehealth needs a lot of support. But ultimately, the clients themselves, the participants themselves, really enjoyed the program. And I think when in the paper we explored that they were coming out of that phase where many of them were locked in their own rooms for weeks and weeks upon end. They were frightened to leave their own houses. And so we came along perhaps at a really good time to offer them an opportunity to improve their mobility and reduce their falls. But it's not for everyone. A lot of the physios said there were a lot of clients that didn't like it because they actually wanted some hands-on therapy. And when you look at the reach of 18%, I expect a lot of people said, telehealth physio doesn't make sense. I want to see a physio where there's a hands-on approach. We excluded significant cognitive impairment, and a lot of the managers talked about the opportunities for people with significant cognitive impairment or hearing and other sensory issues. Would they be able to follow these programs? So in summary, if you're designing telehealth programs or resources, this is probably a mixed message, but I like using older people, and that was really well received in our qualitative analysis. Make sure you use really large fonts on the website. Keep the pace slow and clean. We're doing some looking at developing the website, and surprisingly, some of the people thought my videos, I talk too much. So we need to start thinking about making some really clean videos with minimal important instructions, making sure the technology is easy to use, and really make sure that the resources you're giving them is around them supporting them to do independent exercise. And obviously making sure we have the training and support for this local model of support that's required. And telehealth costs money, and there's no support for allied health in aged care, in residential aged care at the moment, and none for telehealth. And so I just want to thank everybody. So many people were involved in getting my PhD underway and finishing it. And I just want to acknowledge my supervisors, other contributors, and my aged care partners. And I was very fortunate to receive some funding from 3 funding groups, including the CRE. Thank you very much.
All right. Thank you, all the presenters, for sharing your wonderful work. We are right on time. We still have like 15 minutes for question and answers if anybody has any questions.
I can see Richard's hand up, Vithika.
Yeah.
Hi, thanks, fantastic presentations. And I see, Anne, you had your hand up, and I was going to ask you the question. It is the question you must have been asked lots of times, which is how the yoga increased the falls. And one of the quotes that was presented was someone thought it increased their confidence. So do you think there's a misplaced increase in confidence? If I've done a bit of yoga, therefore I can manage that dodgy garden steps or go out to the beach.
Yep, I think so. Yes, so we did have a measure of balance confidence. There was an improvement in the intervention group, but it wasn't a large improvement. I do feel like that must explain the weird results. I mean, there's also the COVID effect, which I wonder about, that people were doing very different activities for a large proportion of that time. And so whether it's, a combination of different things, but I do think that basically the yoga intervention, while it did challenge balance, it was more focused on static standing postures rather than movement. There wasn't functional activities. And we know that many of the effective fall prevention programs do involve training functional activities. So there wasn't any of that in our yoga program.
So a potential confounder was the deconditioning of the pandemic.
Possibly, yeah.
So people were weaker because they were not walking, but the yoga gave them a bit of more increased confidence, and that was the fatal combination.
Yeah, it could have been that, I think. Yeah.
Very interesting.
And I guess, many of you would know that I struggled to get funding to do that trial for many years. So it was highly disappointing, but also by the same token, demonstrates the importance of doing this research, because there was a lot of assumptions over the years that, sure, we don't need to test the effect of yoga because it's exercise, and of course it will prevent falls. So it does show the importance of doing the research.
Absolutely. And the unanticipated effects of research can often be more important than confirming your hypothesis, although at the time it doesn't feel like that.
Yeah. Well, I'll talk to you in a few months and see whether we've had any luck getting it published, Richard, and then I might have a different perspective.
Can I make one comment as a yoga instructor? Just the style, there are many different styles of yoga, and the style that Anne tested, which was Iyengar, is very static, and it uses lots of hand support before you move into balance poses, and it doesn't progress. It doesn't do a lot of transitions, so we don't go from the ground up into standing. It's very static. So there could be that it was the Iyengar yoga doesn't reduce falls at that time.
Yes, and we purposefully wanted it to be a real world situation, a pragmatic trial. We didn't want to modify the yoga so that it was you know, tailored to fall prevention. We wanted to just test what's already out there, I guess.
All right, moving on to the next person, we have Sandra.
Hi, how you going? It was amazing. I loved it. Just need to tell you that I did yoga up until the day I had, and it was Iyengar up until the day I had my daughter. So it can be modified. Were they becoming, do you have any measure if they were becoming more active?
Yes, there was an increase. We had a self-reported measure of physical activity, and there was an increase in the intervention group. It was mostly explained, though, I think, by the fact that they were taking part in the yoga classes.
Okay, so they were, because often, not with the confidence, but if they are becoming more active, then I suppose the exposure to risk of falling is higher compared to if they weren't. So interesting one. Yeah.
I might just comment on that because we absolutely think that exposure to risk could be an issue, and that falls trials should really be analysed that way. But yes, that wasn't the solution here. But as a bigger bigger picture thing, we do think it's important. And just another comment, we do hope to use sort of fancy statistically things to try and understand mediators of the effects as well, and probably informed by the kind of qualitative work that Heidi and Abby have presented, which I think is so helpful.
We have a hand raised from Morag.
Hi, great talks. Thanks, guys. And I just had a question about your WhatsApp groups. How active were they, and how did you go with ethics?
No problems with ethics. So basically, when we went online, we put in an ethics amendment and explained what we were going to do. They were very supportive. Don't know if it was because of the
COVID
situation at the time, but yeah, it was quite simple to switch over to the online. The WhatsApp, they weren't overly active, I have to say. And not everyone signed up, so it was a preference thing. Some groups were more active than others. People shared, photos of their dog on the yoga mat and funny little things like that sometimes. But yeah, they weren't overly active, I would say.
All right, any more questions? Okay, yeah, Anne.
I see Anne.
Yeah, I have a question for Rick. I was just listening to you, Rick. I wondered whether you had much pushback from families about their parents or loved ones taking part in exercise, with the perception that, oh no, they're too frail, they shouldn't be doing that.
All my aged care partners did the screening, and so and possibly I was not very experienced at the time to unpack some of their responses. We worked with the managers of all the different sites, and they sort of indicated how many people they could do. Then the senior nurses went out and identified, according to our eligibility criteria, who was possible, and then they talked to them. And I didn't capture that other than they didn't want to do it. Like, there were reasons, as you could see on my consort flow chart, about why they didn't, and often it was around health reasons. But yes. Family push, and we're investigating doing a facility-wide trial where everyone's there if consent via exclusion, if you know what I mean. So that'll be interesting to see what families think. But I think that people are much more comfortable with health activities on Zoom, maybe not physio exercise per se as much, but we've all done it. We've all seen the GP now, our specialists now, and other health professionals are online, and we see the value in it sometimes, the convenience. Yeah. So,
and you had a photo of a group looking at the TV with the exercise program. Yeah. So did they sometimes do the exercise?
We trialed in the first couple of sites and groups what that was like, but from the systematic review as well, it became very challenging. That's where the fall happened. Right. But a lot of those, I did develop some seated resources throughout the trial for just for those residents and clients that wanted to do some seated exercises. And we're looking at the next trial, looking at developing a much more comprehensive seated program and standing program so that we can offer some physical activity beyond falls.
Yeah, sounds good.
I'll jump in. I just want to
I
comment
see.
on
Yeah.
the reach, because I think actually, Rick, 18% is pretty good. Like, it doesn't sound that much, but I think many trials actually have a lower recruitment rate than that. And you know, this was during a crisis, but also there are the mechanism, the mechanics of actually signing up and giving consent and things as well. Richard might like to comment on that.
Yeah, I was nodding vigorously, Kathy. It's not bad.
And I think that's why it's important, especially in residential aged care, to work out how many people can participate in these exercise programs and the resources required to implement them. So doing small, maximum, I think in a site was 10 people. If we want to do 30 or 40, like I know some other people have done in other trials, that's going to take a lot more sustained organizational support, which may not be sustainable. Who knows?
All right. We just have like last 4 minutes left. If anybody has any more questions. Okay, we have Richard again. Yes.
Oh, I just wanted to make a comment for Rick and the others that there was a systematic review of research done in aged care facilities by a UK group about 10 years ago or more, and they found that overall there was very little research, and what research happened was very poor quality. So huge congratulations of doing high quality research in the facilities. It's innovative.
Can I jump? Thank you, Richard. Can I jump in and ask maybe Heidi or Abby to give any kind of final comments from what you learnt from your work?
Thanks, Kathy. I guess I was just thinking more about, as I was presenting what Anne said earlier, about maybe the reason falls, we didn't improve falls was the concern for safety was paramount, and so they did really. It was what the yoga instructors emphasized the most, is that was the deal breaker for them. If it wasn't going to be safe, they weren't going to do it. So they were very conservative, more conservative than they would be in a class. So yeah, I hadn't sort of thought about it. I hadn't put the two together as much as now, so that was good.
I think for myself, it's moving away from our primary outcome. There was a huge amount of benefit that people got from SAGE, including the online classes, which really did surprise me. I have to say, I picked up my own bias going in. I definitely would have advocated for for group classes that facilitate that greater social connection. But I was surprised by how many people found that online classes were actually more effective for them. So I guess it's about, again, it's going back to that principle of choice. It's horses for courses, but it certainly worked for a lot of people in many respects, regardless of falls.
Yeah.
Was that over, and do you think COVID played into that, Abby? Or do you think, like, I'm just trying to, like,
Certainly,
is it
the
that
first round of interview, the first round of data collection, definitely, people were anxious for any kind of engagement, social or physical engagement that they could do safely. So yes, but I think in the second round of interviews and focus groups where we'd really come out of that, we saw the same mechanisms in operation. So I think it probably increased the positive effect, but I think there's definitely an enduring positive effect.
Yeah, and just to add to that, I was thinking that the yoga instructors in their own practices had all returned to face by the time we'd finished interviewing them in their daily practice, except for the older adults. They'd chosen to stay outside the trial. They'd chosen to stay in online classes, and that was quite telling.